All right, good morning. We are, because of the cold weather, we don't have all the students here today. I'm not sure who's coming and who's not. So I'm going to give it about 5 minutes before we get started. So those of you that are joining us online, will be starting in about 5 minutes. Oops, nope.
What's the matter?
We don't have OBS up. My camera's not working. Let me sit for a second, please.
Do I need to reset the camera?
No, it's OBS, not the camera.
Got it.
Okay, so we're gonna do this. Okay, those of you joining live, technical difficulties will be right with you. Always technical difficulties. All right, now I think we are ready. Okay. Good morning. You sure it's not a Monday? Anybody sure it's not a Monday? Feels like a Monday. All right, so between last class and today, you guys had chapter 7, which was a skills chapter. Shouldn't have been too terribly difficult for you. Does anybody have any questions on chapter 7? This is going to be on the quiz is on page 187. Does anybody have any questions? No? Yes? PPE? Personal protective equipment? Okay, so in your book,
Also the PPE kits.
yeah, I need a book. Thank you. Good morning. So in your book, let me get the page number for this. I have a whole lesson on this to help you out. If you go to page 124. Page 124 talks about standard and transmission-based precautions or isolation precautions. So standard precautions is what we use with everybody worldwide. Doesn't matter who you are, where you came from. If we're going to touch body fluids, we need gloves. If we're going to touch personal skin, we need gloves. If we're going to touch non-intact skin, we need gloves. We use that with everybody. Doesn't matter what they're here for. If we're going to touch any of those three, we need gloves. Okay, that's called standard precautions or universal precautions because it applies to everybody. And that's because we can't tell by looking at you whether you have a communicable disease. No problem. We can't tell. Like, I can't tell by looking at you if you've got hepatitis C, or I can't tell by looking at you whether you have MRSA. I can't, there's no LCD screen on our foreheads that say I'm infected with. And the problem is that a lot of times you guys won't even know. You haven't been diagnosed yet. Maybe you don't even have symptoms because there are a lot of diseases that have a prolonged incubation period where you're able to pass that thing on, but you don't even know about it. Okay. So we use standard precautions with everybody because we don't know what you've got. Now, once we know that you have something, so once you are diagnosed with hepatitis C, we're still going to use standard precautions, but we're also going to add another layer of precautions, and this is called transmission-based precautions. So universal is for everybody because we don't know what you've got. And transmission-based precautions, we know you have something. We have to take steps to avoid passing that around. So a lot of people know this as isolation. And there's a couple different levels of transmission-based precautions because it really depends on what you've got. Okay, so if you've got TB, that spreads completely different than hepatitis C. And if you have measles, that spreads completely different than somebody with MRSA. Good? Does that make sense? So we have to know not just what you have, but how it spreads. And then based on that information, we're going to develop additional precautions for our healthcare workers to take. So if we have somebody who has, let's say, hepatitis C, we'll stick with that one, that is spread through blood and body fluids. So it doesn't spread through breathing it in. So we really don't have to do anything here. But we probably want to cover our clothing, and we definitely want to wear gloves. Okay, so that's one type of PPE. Now, if you have measles, that's airborne. That floats in the air. It's one of the very, very few things that actually floats in the air. So if you have measles, well, now we got to cover all of this because we don't want, if it's in the air, everywhere we walk, we're going to encounter it. So we want to have a mask and goggles and gown and gloves. We're going to have the whole thing. Now, maybe you have something that is spread by droplets. And COVID was droplet spread. So that means that when I talk, little bits of saliva are coming out, but they don't go very far. They're not airborne. They're heavy. So they tend to fall. So about 6 feet around me has the potential to have contamination, right? Do you remember during COVID, we told you to stand how far away from other people? 6 feet. So we used what we knew and applied it to COVID. Does that make sense? So if it's droplet, well, if we're going to get super close to the patient within 6 feet, then we probably want to cover our holes up here. But if we're not getting super close to the patient, if we're just going in and, I don't know, restocking the linens, right? We don't need, we're not super close to the patient, so we would need a different level of protection. Does that make sense? So when your patient is diagnosed with something communicable, we have infection control professionals. This is their whole life. They eat and drink and sleep infection control. And that infection control person will decide what level of protection is needed for each of the healthcare workers that enter the room. And that's actually going to be printed on a card that you can see on page 124. Your facilities cards may look a little bit different, but it's going to indicate what PPE is required. Good morning. Okay. Yes. Hi, good morning. Today is my first day. How many do I have to follow to get the exam? Okay, so Stefani, we're not based on, or we're not tied to the exam in any way. If you're in Florida, you can challenge the exam at any time. You don't need to take any classes. You don't have to complete any level of, or any number of classes to be eligible to test. Go watch class 4 for test registration and instructions. You can watch the replay. However, if you're in any other state, you're not eligible to test unless you take an actual CNA course through your state. So if you're in Georgia or North Carolina or New York or anywhere else, you have to go through your state's training to be eligible to test. Now, we're actually being streamed into some classrooms right now. So a lot of classrooms use our live stream as part of their curriculum, but you would be certified to test through them, not through me. Hope that makes sense. Okay. All right. So if we have a patient that has a contagious disease and they're on isolation and we have to employ these measures, whatever's on the door, the little card that's taped on the door, we have to know how to put them on and how to take them off. You have to know this. You will have a test question about this. You will have a written test question about this. Now, did anybody watch my game show yesterday? Anybody watch that? Okay, my game show yesterday was all on infection control, the types of questions you would see on the written exam for infection control. So if you did not watch live yesterday, you probably want to go back and review that because it gives you 15 questions that could potentially be on the test. And one of them was, what order do you put PPE on? Now, you could probably figure this out just based on what you already know about infection control. What is the first thing our gloves touch? The patient. So if we are putting on mask, goggles, gown, and gloves, what do you think should be done last? The gloves. Does that make sense? Right? So just based on the information that you already know, you could figure out the order of the choices that they give you. Does that make sense? Everybody good with that? Okay. So, the lesson on page 124 and 125 goes over that. You're probably going to want to read that at some point and answer those questions so you have a really good understanding of these topics. All right, so let me go ahead and get your scores for chapter 7. Paula. That's fine. Do you have 5 and 6 for me by any chance? If not, I'll ask on Monday. Monday? Okay. Olivia? Thank you. Cindy? Thank you. Gabriella? C. Okay. Do you have, I need 4, 5, and 6 from you. Do you have those done? How many did you miss?
4 and 6.
6? Okay.
And 5, 4.
Okay. Okay. And 6?
6, 4.
Okay. All right. If you're having any trouble, let me know. Come see me after class. Melissa? Ariana? Fabrice?
95.
Thank you. Brianna D?
95.
Thank you. Antonio? Thank you. Gabrielle H? Daniel? Thank you. Drew? Brianna R? Amara? Mahala?
95.
Thank you. All right. Any questions on any of that? Everybody good with that? Good morning. So this is the order that you put it on. So if we have to wear gown and mask and eyewear and gloves, this is the order we put it on. We put the gown on first, then we put our mask on, then we put our goggles on, then we put our gloves on. Now, when we take it off, there's a different order because you don't want, so remember, when we're taking it off, our gloves are dirty. We don't want to put dirty gloves up next to our face. Remember, these are doorways in. So we have to make sure that we take our gloves off before you reach up here. Right. Donning is putting on. The word on is in there. Doffing, the word off is in there. It's taking it off. Good. Any other questions? All right. Okay, I'm going to go through this. This is a quick 15-minute review. I'm not going to make you recite them, but this is our last review. This is it. All right, so we perform every skill as directed on the care plan. We follow the care plan, the whole care plan, and nothing but the care plan. While we do that, we observe for any abnormalities, and we report those abnormalities to the nurse. This is our whole reason for doing what we do. Every skill starts with an opening. Every opening starts with a knock. So we knock. We address the patient by name. We introduce ourselves by name and title and describe the skill that we're there to do. We get permission, close the curtain, wash our hands, and then go get the supplies. Remember that you have to have clean hands to get your clean supplies. Our cardinal rule here is do not touch the patient until your hands are clean. That's what they're grading us on. If we need gloves, there's some rules that apply to them, but we don't wear gloves for everything. We've got to figure out when we need them. So if there's a potential that you're going to touch body fluids, you need gloves. If there's a potential to touch personal skin, you need gloves. If there's a potential to touch non-intact skin, eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions, you need gloves. But if you wear gloves, the first thing they should touch is the patient. If you wear them, we have to know how to remove them correctly. And remember, skin can touch skin. Skin cannot touch dirty gloves. Also, be aware of what you're touching in the environment with those dirty gloves. Because if you've got body fluids on your hands and you start touching stuff, now those body fluids are everywhere. Good. If we need supplies, we're going to get a barrier. And we always get the barrier first before we get our supplies. And we spread that out. That gives us a clean place to put our clean supplies. Remember, you only can touch supplies with clean hands. Don't hold those supplies up against your uniform. Privacy blanket is used anytime the patient is uncovered or undressed, and we use it to keep our patient warm as well as protect their privacy. To put it on, we don't snap it or shake it. We lay it on top of the sheet. We pull the sheet down underneath. That way the patient is always covered. And at the end of the skill, if we used a privacy blanket, we have to take our gloves off before we remove that privacy blanket. Any questions so far? This should not be foreign to any of you. In fact, you should be like on the verge of sleep by now. Linen rules. Linens can't touch. These are all repeats that we've learned before. Linens cannot touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. But then we got these two that are somewhat new. We've learned them, but they haven't shown up in any other principles. And that is clean rolls toward me, dirty rolls away. And we're actually going to see that again today in one of the skills that we're going to learn to do. So this principle is very, very important. Clean rolls toward me, dirty rolls away. And it doesn't matter whether we're doing a big sheet that's on the bed or a little chucks that's under the patient. Same process. We don't let anything touch floor. Not clean, not dirty. Nothing goes on the floor. And if you take things that you don't use, you have to discard them. You can't leave them in the room for later. Patients always have to be in the middle of the bed at all times, and we can't rely on side rails to keep them safe. Side rails require a doctor's order. So in order to keep the patient in the middle of the bed, you have them scoot towards you and then roll them away. Remember, we always roll them away. We remain behind, they're behind. But the rule here is that the patient needs to remain in the middle of the bed at all times. Washing rules. We do a lot of bathing, a lot of bathing. That's like the main thing that we do is keeping our patients clean. So with bathing comes bathing rules. We don't put soap in the basin. That way we have clean water for rinsing. We use paper towel to turn that faucet on. That's important because your hands are clean. We don't want to contaminate those hands. We're going to check the water with the inside of our wrist. It should feel warm, not hot, not cold, just warm. And then we're going to ask the patient to check it as well, because what I consider good for the patient, they may disagree. So we have to give them the option. We use leaves method for wet body openings. We learned that last class. We're going to see it again today. And we don't get our surface wet. So we always protect our surface. So when we did partial bed bath, the surface was the bed. So we put a towel down. With hand and nail care, the surface is on the table. So we put a barrier down. With foot care, the surface was the floor. So we put a barrier there. We just want to protect that surface that we're working on and keep it from getting wet. Anytime we use lotion, we warm it up first and then wipe off the excess. Basins are all clean the same way. You rinse it, you dry it, you store it. That's all that's required for the test. Rinse it, dry it, and put it away. But when you're putting it away, you still have dirty hands or dirty gloves. So you need a paper towel between your hands and the drawer. Good. Shoe rules. If the patient's feet hit the floor, we got to talk about their shoes. Slipper socks are never enough. We never, ever, ever walk a patient in slipper socks. If the patient doesn't have shoes, for whatever reason, let the nurse know. And the nurse can get a hold of the social worker and we can solve that problem. We can't solve it if we don't know that there's a problem. Incidentally, if the patient doesn't have shoes, and we have to get them up and walk them to the bathroom or wherever it is that we're going to go, put a second pair of socks on them and then remove that second pair before they get back into bed. That way they're not transferring pathogens from the floor, especially bathroom floors, into bed with them, right? Does that make sense? So if no shoes, second pair of socks will work in a pinch, or change those socks out once they get into bed, whatever. But that infection control really does need to be addressed. Shoes are best because in a clinical setting, we can have sharp objects on the floor that we're not aware of. If we're going to walk a patient and we're going to use a gait belt, we put it on and we check it with 4 fingers. Don't leave it too loose because that can actually cause injury. So you want it snug around the patient's waist. You're going to ask them to put their hands on your shoulders and you're going to count to 3. That way you're both working together. You're going to use that proper body mechanics. 1 foot in front of their feet, 1 foot beside them, and you're going to lift them on the count of 3. Stand there for a minute, ask them if they're dizzy, make sure that they've acclimated before you start walking. When you return them to the chair, you turn them around and ask them to tell you they can feel it with the back of their knees. Never ask a patient to trust you that there's a chair behind them. We have to make sure that they know there's a chair. And then we want to always make sure we're using proper body mechanics when we're lifting and lowering the patient. That saves you, but it also saves them as well. And then every skill ends the same way with the closing. We ensure a clean environment, bed height in the lowest position, ask about the patient's comfort, offer a magazine, ensure they're covered. Remember, no knobby knees. Open the privacy curtain, give them a call light, and then you can go wash your hands. After you've done all of that and washed your hands, document if necessary, and then wash your hands again because we have to end skill with clean hands. Any questions on those? They're all covered in the flashcards, but so are these. These are also in the flashcards. So if you're lost at all, if something is not clicking with you, get the flashcards because it's a great review. So when we're taking a pulse, we're going to support the arm, make sure it's not hanging off of the bed and it's not, up in midair. You're going to not use your thumb. We're going to use 2 fingers, fingertips, not the flat part. And the pulse is located on the thumb side of the wrist, way up here, not down here. Remember, you need to be on the thumb side of the wrist because it is the radial pulse. 60 to 100 is normal. You're going to count with 2 evaluators for the test here in Florida. So you'll count with evaluator number 1. They're going to let you write that down. And then you'll count with evaluator number 2, do your closing, wash your hands, document, wash your hands again. Because you're counting with the evaluators, they need to know when you're starting and stopping. So you actually need to say out loud, start when you start counting and stop when you stop counting. Same thing for respirations. We're going to say out loud when we start and stop. We also learn how to dress a resident. We ask about clothing. We're going to minimize exposure by getting the clothing before we undress the patient, make sure they're covered at all times with a privacy blanket, even though we're dressing them. We lift from below with a flat palm. We're going to support all joints when lifting. We'll undress strong arm first, dress weak arm first. Make sure everything is lined up right, toe seams across the toes, pants over the hips, buttons buttoned appropriately or snapped. Don't overextend or force movement. All dirty items go in the hamper. Can I put them on the floor? Never. And then put the call light in the stronger hand. Hand and nail care. It's a mini manny. We're going to do all of our washing rules. We'll soak the hand, take it out, put it on a towel to wash it, put it back into rinse, take it out, put it on the towel to dry, clean under the nails with an orange stick, wipe it off in between, file the rough edges with an emery board in one direction only, and then apply some lotion. So we warm it up, we wipe it off. Good. Making an occupied bed. We're just changing the bottom sheet a half of the bed at a time. We use clean rolls toward me, dirty rolls away to make that happen. But while we're doing that, the patient needs to be on their side in the middle of the bed. They take up less room that way. So we need to scoot them toward us, get them on their side, and then we'll take the dirty bottom sheet, roll it up toward the patient, shove it under them, put the new sheet on because we don't want that patient laying on a bare mattress. Good. Minimize wrinkles whenever possible. We don't like wrinkles. We want to try to smooth that sheet out as much as possible. Once we get the top sheet on, we can remove that privacy blanket. We'll tuck that top sheet in and make hospital corners. Good. Make hospital corners. Doesn't matter how pretty they are. Nobody cares. Pillowcase is changed with the opening of the pillow facing away from the door. Side lying position. If we have to turn a patient over on their side, we got to prep them first. So furthest arm goes up, closest arm goes over. Closest knee is bent, furthest knee is angled. And then you just roll them on their side. But if you don't move them towards you first, they're going to roll right off the bed. So remember, scoot and roll is important here. But arm up, arm over, leg bent, leg angled. Get them on their side. Put a pillow behind the back to hold them there. Gravity will pull them on their back, guaranteed. Gravity will always pull you back onto your back. So you got to have a pillow there to keep them on their side. One in between the legs, particularly between the knees and the ankles, so those bony areas don't rub. One under that top arm, and adjust the one under the head. Call light in the bottom hand. Foot care, just like hand and nail care, a little lower, hard to get up off the floor for me. Most of you won't have any problems with this. We're going to put the foot in the basin to soak, take it out, put it on a towel to wash, put it back in the basin to rinse, take it out, put it on the towel to dry. Nothing with the toenails. We don't file, we don't clean, we don't do anything with toenails, but we do look. If the patient has a toenail need, who should we be telling? The nurse, absolutely. Once we wash, rinse, and dry and look, remember looking is the main part of this, then we can apply some lotion. Don't put lotion between the toes. It holds in moisture, can contribute to athlete's foot. Make sure their bare feet don't touch the floor. You need to have the barrier there. And then put their sock and shoe back on. Pretty easy. Mouth care. Yeah, you guys all know how to do mouth care. You have brushed your teeth at least once this year, I promise you. You know how to do this. If you didn't, please do. Right? You know how to do this. but your patient's laying down. We got to get them sitting up for this particular skill. So make sure you get them in a sitting position before you start brushing their teeth. If you do it before you wash your hands, that's fine. Just don't touch the patient. If you do it after you wash your hands, use a paper towel to touch the buttons to minimize contamination. You're going to wet the toothbrush, put some toothpaste on it, make sure you have a clothing protector on, and you're going to brush everything that the patient has. But because we're touching body fluids, we need to wear some gloves. First thing that those gloves should touch is the patient. So you're going to do all of that prep work first. Then get your gloves on and brush their teeth. Let them rinse and spit as much as they need to, whatever that takes. If you use a lot of toothpaste, they're going to be rinsing and spitting a lot. Little toothpaste, this makes it easier on the patient. They don't feel like they're choking. Little toothpaste is better. After they rinse and spit, make sure that you leave their mouth clean and dry before you go over and clean your basins. Respirations, we're counting their breathing, but we don't want them to know that. So we don't tell them we're counting their breathing. We tell them we're taking their vital signs. Normal is between 12 and 20. In and out, the whole thing counts as one. Normal is between 12 and 20. For the test, you can put an alcohol pad or something on the tummy to actually see the breathing a little bit easier. It's easier on the evaluators too, to be able to see that. Because we're counting with evaluators, we're going to say start when we start counting. We're going to say stop when we stop counting. And for the test, there is a clock right above the bed. There has to be a clock right above the bed. That's one of the testing parameters. So everybody's using the same timekeeping device to measure. This is a documentation skill, so make sure you document after you do your closing. We learned a couple range of motions. Remember range of motion? We do exercises to retain function, not regain function. So we don't like pain. We don't do pain. All movement should be slow and smooth, a full range of motion or up to the point of pain, supporting the extremities from below. And then we have to return all the way to start for it to be a full range of motion. We want to watch their face for any signs of pain, grimacing, wincing. You want to feel if they're resisting at all because of pain. Use your senses to gather information here. We don't like pain. We're just going to follow the care plan. Flexion extension is up, down. Abduction, adduction is side to side, and rotation is around. Follow your care plan. It'll tell you what body part, what exercises, and how many repetitions. We also learn how to do denture care. With denture care, it's mouth care plus an extra step. We're going to take the dentures over to the sink and clean them. Then we come back and clean the mouth those dentures came out of. But when you're cleaning the dentures, you want to make sure you protect those dentures by putting a washcloth in the bottom of the sink. We don't want to drop them. You don't want to touch dentures unless you have gloves on. Remember, body fluids. When we're done cleaning the dentures, we're going to rinse that denture cup out, fill it up with cool water, put the dentures in it, and we want a coaster underneath to prevent warping of whatever surface we put that wet cup on. Then we'll go over and do mouth care. Same mouth care we just talked about. Make sure they have a towel or something over their clothing. Wet your toothbrush, get some toothpaste, brush all surfaces. This time we're going to use a toothette though. Spongy, you've got one or you've got two in your kits. Use a spongy toothette because that helps take away any denture paste that might be up against the gums. Throw that away when you're done. Always leave your patient clean and dry at the end. Ambulate with a gait belt. We learned this last class. We apply the gait belt while the patient is sitting. We apply it over or around their waist over their clothing. I don't know why I have to tell you that, right? Don't take their clothing off to put a gait belt on. We want to help them to stand using that gait belt. We're going to hold the sides or the back. Their hands on our shoulders, 1 foot in front of their feet, 1 foot beside. I don't have the graphic there. 1 foot beside, that body mechanics. On the count of 3, we're going to stand. Let them stand there for a second, acclimate. And then We'll ask them if they're dizzy and let them lead. While they're walking, we're going to hold behind in an underhand grip. That way we can feel if they start to get all wobbly or slow down. And for the test, it's 5 steps in one direction, turn around, 5 steps back. Super easy. When you get them back to the chair, back them up so the back of their feet or back of their knees hit that chair. Help them sit, remove that gait belt, but don't slide it around or, over their skin. You're going to loop it around. And make sure that they're just seated properly. Partial bed bath. This was the last one that we learned. This was the first time we learned that leaves method. We're going to see it again today. So partial bed bath can be shortcutted into face to waist, front and back. We want to wash the face first, no soap. No soap on the face. And then you're just going to wash from the face to the waist with soap. Whatever we wash, we rinse. So let's rinse it. Whatever we rinse, we dry. So let's dry it. Put a new gown on, turn them on their side, wash, rinse, dry the back, give them a little back rub, tie that gown. That's pretty much it. It's a long skill. Oh my gosh, this is such a long skill. This skill took me an entire day to tape for the new videos coming out. I did this skill no less than 8 times so that I could get different camera angles and show you different things. This is a long skill, guys. It absolutely is, but it's not a hard one. If you get this skill for the test, you get 2 super short skills to go with it. Super short skills like range of motion, elbow and wrist, and respirations. Super short skills. All right. Wow. Look how much you've learned. Look how much. I want you to stop for a second. Look how much you've learned in 3 weeks. Not even 3 weeks. Because I haven't got to today's lessons yet. You've learned a lot of information in a very short time. I'm very proud of all of you. You've done a great job. We're not done yet. But at this point in the program, it can start to get a little overwhelming because you have learned so much. So I want you to take a minute and just soak in the fact that you guys are doing fantastic. And we're going to add to that. But we're almost done. We have 3 skills to do today, and we have 4 skills to do on Monday, and that's it. You're on the home stretch, and there's nothing new to learn. You've covered all of the principles. What we're going to do now is start bringing those principles into different skills. Okay, so nothing new to learn with principles, but we have to bring them into different skills. Now, what we're going to learn from here on out instead of principles are things that are related to the skill itself. So today we're going to learn about transferring out of bed and into a wheelchair. I've got a lot to tell you about this, but it's all based on the wheelchair and safety. We're going to learn about Peri Care today. And I've got a lot to tell you about Peri Care, but it's all based on the urinary system and how it works. And you need to understand that in order to be able to do the skill appropriately. We're going to learn about feeding a patient. Now, all of you guys know how to eat. I know this isn't a hard skill. I've got a lot to tell you about feeding a patient, but it all has to do with measuring intake and output and why feeding doesn't follow all of our normal rules. So we have a lot to learn, but it's based on the skill itself, not on principles. Good? This is why I teach in a very specific order. So by the time we get here, you know all of that. You can recite those in your sleep. We're going to apply those, and we're going to learn some things that are specific to that skill. So if you go to page 72, you can see our overview of transferring from bed to a wheelchair. So if you look down here, you can see the principles involved. They're all spelled out here as well. We know to follow the care plan, do our opening, evaluate if we need gloves. Shoe rules apply here because we're going to use a gait belt, and we're going to do the closing. I have a video for it. Short form of the skill is here. Test specific is here. I want to go over this real quick. Testing info. Somebody with your level of experience should be able to get a patient out of bed and into a wheelchair in 11 minutes or less. It should not take you 11 minutes to get a patient out of bed and into a wheelchair. Should not take you 11 minutes. This is at most a 5-minute skill. Now, the reason that I say that is because when you go out there and you start working, you're going to be slow because you're new. You're supposed to be slow. You're new. This is the one time in your life that you can get away with being slow. But the problem is, if you're too slow, you're not an asset to that facility. So even though the test is saying, yeah, somebody with your level of experience should be able to do this in 11 minutes or less, understand that you want to aim for something much quicker than this. So a lot of what I'm going to teach you about this skill is to kind of get over some of your fears and misconceptions so that when you actually get to doing the skill, you can just get in there and do it. Okay? And we can go a whole lot quicker than 11 minutes. This is a live testing studio. That means that you might be a patient for this. Somebody might have to take you out of bed and put you into a wheelchair. If you are the patient for this, you are going to get very specific instructions, and we're going to get into that now. So at top page 73 is our care plan. The care plan tells us to transfer the resident from bed into the wheelchair. The resident is unable to walk or take steps. I want you to underline that where it says or take steps. What is this patient unable to do? Take steps. This is the number one reason that people fail this skill, is those two words. Because if you don't get the wheelchair close enough to the bed, when you stand that patient up and turn them around, if that wheelchair isn't right there, what are they going to have to do? Take a step. And what can't they do? So if you are the patient for this skill, that evaluator is going to tell you, do not take a step. And then the person doing the skill gets all tangled up and it becomes a problem. Okay, good. It does say that they can stand with support though. Yay. So their legs work, guys. They just can't take a step. Their legs work. They can stand with support. Says a gate belt or transfer belt is required to transfer the resident, and they'll stay in the room. Yes, they're going to stay in the room. That's where this scene ends. No, normally, if we put a patient in a wheelchair, we don't leave them in the room. They're going somewhere. They might be going to therapy or to an activity or to a meal or whatever. Usually, if we put somebody in a wheelchair, we don't leave them in the room. But for the test, this is where the scene ends. Does that make sense? But if we're leaving them in their room, we have to think about how they're positioned. Because if I leave somebody in a room facing a wall, growing up, now most of you guys are young, but growing up, did you ever hear about somebody having to stand in the corner for punishment? You familiar with that? Yeah, if you leave a patient in a wheelchair, remember they can't get out of the wheelchair by themselves. If you leave them in a wheelchair facing a wall, that's exactly what you're doing. It's just like putting a child in a corner. It makes them feel like they're being punished. So if you're putting them in a wheelchair and you're leaving them in the room, what direction should they be facing? Yeah, the TV, the door, something, window, something other than the wall. So for this skill, make sure that you're turning that wheelchair around. Are you starting to see that it's not the steps? It's all about the patient for the test? Good. Okay. So this tells us our step-by-step instructions. Down here we have our supplies. But this little graphic right here at the bottom of the first column, it has a bed and a wheelchair and a person. You guys see that? Do you see how close that wheelchair is? That is what we're looking for. That wheelchair should be almost touching the patient. In fact, I would even say that this wheelchair is probably a little too far away. My guideline when I'm going to transfer somebody is I should only be able to fit a sheet of paper between that patient's leg and that wheelchair. That's it. Any more than that, they're going to have to take a step. And that means I'm going to be bearing their weight a whole lot longer. I don't want to work that hard. All right, any questions so far? Okay, so shoe rules are going to apply here. If the patient's feet hit the floor, we got to talk about their shoes. But they were laying in bed, which means that all they have on are slipper socks. So your patient for the test will be laying in bed. They're going to have socks on. But when you get them sitting on the edge of the bed, you've got to physically put their shoes on them. If you remember what I said the other day, if you are a patient for foot care or transferring, or if you're going to be doing foot care or transferring, they're going to look for a patient for you about your body size or smaller that is wearing slip-on shoes. And that just makes this skill a little bit easier. They're looking out for you. Now, if we can't find anybody that fits that criteria, then they'll take somebody that has tie shoes. But they're trying to make this a little quicker for you. Make sense? Good. All right, so we get the patient sitting on the side of the bed. We get their shoes on before we transfer. Now, I'm going to tell you, there are some schools that teach you to put the patient's shoes on before you get them sitting on the side of the bed. But now you got shoes on sheets. I don't think that that's a good infection control strategy, right? If you do that, what do you think you should do with the sheets after the patient's out of bed? Change them. Yeah. So slipper socks are not enough. We know this. You got to have shoes on to transfer the patient. Once you get them sitting on the side of the bed, we're going to check that gait belt. Make sure that it's tight enough. It's around their waist, over their clothes. We should only be able to fit 4 fingers between us and the gait belt. Once we get that gait belt on, you're going to make sure that those feet are flat on the floor. And I want you to ask the patient, are your feet flat on the floor? Don't just take a quick glance, because you may not be able to see that their heels are this much off the floor. It may not be visible to you, but just that little bit can cause the patient to topple forward. So ask them, are your feet flat on the floor? We're going to count to 3, their hands on our shoulders. We're going to use that same body mechanics, 1 foot in front of their feet, 1 foot beside. Count to 3, and we're going to stand them up and turn them around. Now, one of our rules, though, is that they have to feel that chair behind them before we sit them down. So I want you to think about that. If I have a patient in bed and I lift them up and turn them, and then I stop and I ask, can you feel the chair behind you? And they've got to feel, yeah, I can feel the chair. Okay, we're going to sit. That is a whole lot of time to hold that patient in place. I don't do that. I know the patient has to feel the chair behind them. So what I do is I tell the patient while they're sitting, I'm going to lift you up and spin you around. When you feel that chair behind your knees, I want you to say sit, and I'll lower you into the chair. And then I put my hands around the gait belt, their hands on my shoulders, and I'm going to say, remember, when you feel that chair behind you, say sit. Ready? 1, 2, 3, up, over, sit. There we go. It'll save your back. They have to know the chair is there, but we can prepare them before the transfer. Good? Any questions? All right, so remember our care plan says they're unable to walk or take steps. So a wheelchair that's this far away is not going to help this patient. They would have to take multiple steps to get to that wheelchair. And this is what the test is looking for. We want to make sure that that wheelchair is super close to the patient. So let's talk about tests or a wheelchair specific things now. So this is a wheelchair. It's actually the same wheelchair you see up here. live. Here it is. Now, the thing about wheelchairs, so important, is that they have brakes. Now, the problem is that floors are rarely completely level. Concrete floors tend to crack because they settle. On Florida, we just have sand. We don't have soil. So most foundations crack. That means that we don't have a completely level surface. Wooden floors warp with temperature changes. So a wooden floor can have lots of different heights. So if the floor isn't level and we have a patient in a wheelchair and that wheelchair starts to roll because the floor isn't level, there's nothing that's going to stop that wheelchair except for whatever the patient runs into. You guys see how that could be a problem? So brakes become very important. If a wheelchair is not actively in motion, the brakes should be on. So in order to know how to apply the brakes, we have to know where they are. So wheelchairs are usually kept in the folded position for storage. This just gets them small and makes it easier to store them. To prepare a wheelchair for use, you just lift up on the handles to get the big wheels off the ground because otherwise there's too much friction. So lift it up just a little bit and pull it apart. That's it. To close a wheelchair, you're going to lift up on the center of the seat and it goes back together. Now, some wheelchairs are a little stiffer, a little harder to open. You might have to open it a little bit and then press down on the seat bars. But they do open manually. There's no button to push or lever to pull. It's just manual. So once we have a wheelchair open, we have to know where all the other components are. So the brakes are going to be located in front of the wheels. Now, I do want to tell you there's a couple of different types of wheelchairs. A true wheelchair has big wheels, which is what you see here, big wheels. This is a wheelchair. But have you ever seen a chair that has 4 small wheels on it? Anybody ever see those? A chair that has 4 small wheels is actually called a companion chair. And it's going to work a little bit different. Those chairs, are designed for people who can move themselves around in the chair. So the brakes are not as easy to reach. They'll actually be on the wheels themselves, lower to the ground on the little wheels. But if we have a wheelchair and we're responsible for the patient in the wheelchair, it's got to be locked. So this is where the lock is. And this is how a lock works on a wheelchair. It's very mechanical. You have this metal bar right here that bites into the wheel. That's what stops it from rolling. This metal bar bites into the wheel. So this is unlocked because there's a gap. This is locked. So right here, you guys can see it. This is the lock. Right now there's a gap and the wheelchair rolls just fine. This is unlocked. If I want to lock the wheelchair, I'm going to move that lever and that bites that metal into the wheel. And now that wheel does not roll. Some wheelchairs you pull back to lock. Others you push forward to lock. Different manufacturers do locks a little different. Just make sure, doesn't matter, make sure that the metal bites into the wheel to stop it from rolling. To unlock it, you just move the lever in the opposite direction. Good? Anytime a patient is in a wheelchair and it is not currently in motion, it has to be locked. Floors are rarely level. Now this one you can actually see. Do you see that hump there? You guys see? You see with the light reflecting on it, there's a hump there. Floors are rare. And this is an actual hospital here locally. Floors are rarely level. This is very important for the test. Now, something that you probably don't know is that all the checkpoints on the test are there for a reason, and that reason is usually generated by a lawsuit. And this particular step was generated by this lawsuit. There was a patient in 2004, this is in Florida, and at the time it was the largest negligence verdict. There have been bigger ones since. But back in 2004, a dementia patient was strapped into a wheelchair with a gait belt, which is illegal. That is a restraint. Strapped into a wheelchair with a gait belt. The wheelchair was unlocked, and this dementia patient was able to find their way into a concrete stairway and went right down the stairs.
So you take the gate belt off before you go do anything else.
Yeah, well, it wasn't just the gate belt on, it was around the wheelchair. It was used as a seat belt, and that's illegal. So yes, we would definitely don't do that, but take the gate belt off. But first, this dementia patient should never have been able to access this. Somebody prop the door open. That's a problem. Second, the wheelchair, because she has dementia, the wheelchair should have been locked. She should never have been able to go with that wheelchair. And third, we don't strap patients into wheelchairs. So there was a lot of contributing factors to this, but it was absolutely horrible. Can you imagine being the patient that this happened to? Can you imagine? Horrible. So wheelchairs are not a restraint. They're a safety measure. If somebody can move around on their own, they'll just unlock the wheelchair and go anywhere they want to go. It's not a restraint. Patients are able to get to the locks and move them. It is a safety violation if you don't lock the wheelchair. Good? So all wheelchairs should be locked when not actively in use. This is something that most of you guys don't know. And I wish I had one of my red chairs here for you to show you. You can see it on the screen though. Do you see the height difference between the wheelchair and the chair? Same thing with this, okay? Wheelchairs are higher, taller. The seat is raised specifically because a wheelchair is designed to move somebody around. We don't want their feet flat on the floor. If somebody's feet are flat on the floor, it's going to be hard to move them. So wheelchairs are always taller. Now that's a problem, and it's probably not one that you would recognize right away. So because wheelchair seats are taller than chairs, it means that the patient's legs are going to dangle. And that becomes a circulation problem. When the legs dangle, you've got arteries and veins that run down the back of each one of your legs. Right here at the knee, they become smaller and branch off. And this is exactly what's going to get compressed at the edge of the seat. So when that happens, when we have somebody's legs that are dangling and this area gets compressed, all of the stuff from down here can't make it back up. So when we have a seat that is compressing that area, all of this blood down here can't go back up to the heart. And because it can't go back up, it has to stay in the lower legs. So we get swelling. But anytime blood slows down or stops, do you guys remember what it does? It clots. So what is this patient at risk for? Blood clots. So when we have a patient sitting in a wheelchair, we just don't let their legs dangle. They have to be supported on footrests. That relieves the pressure against the backs of the knees. This is actually what the inside of your veins look like, because veins take blood back to the heart, especially in the lower extremities. It's a low pressure system. So it doesn't just, it's got to fight gravity, right? It's going from low to high. So we've got these little valves in there that close. So each heartbeat pushes blood through the valves and then the valves close. So now this blood is up here. The next heartbeat, this blood will be up in the next chamber. And this is how it works. But these valves themselves can trap blood in there if they're compressed. So we end up with blood clots in the veins. Well, all veins lead to the heart. That's dangerous. That is dangerous. Good. So we're going to use foot pedals to support those feet. If there are no foot pedals on the wheelchair, you need to notify the nurse. Don't ignore it. This is not a, well, it doesn't matter type of thing. This is very, very important. And the thing about foot pedals is that they come off very easily. So what ends up happening is that caregivers will take these off and they'll put them somewhere, and then the next person can't find them. So if you're putting somebody into a wheelchair and there are no foot pedals, it has to be addressed. You need to let the nurse know. Go find the foot pedals. These just sit on, there's two little like posts here. This just sits on the post. That's it. That's how you put them on. There's two parts to this. There are leg rests and foot pedals. Two different pieces. The leg rests have to be swung forward, and you'll hear it click into place. So listen closely. You hear that click? That lets you know it's in place, and now it's not going to move. It's locked in place. To move a foot pedal or leg rest out of the way, we can't put somebody into a wheelchair with these leg rests in the way. They'll trip over them, and somebody's going to get hurt. So to move these leg rests out of the way, there's a little catch on the back side of the post. You just pull the catch forward, and they swing out of the way. This is the position a wheelchair must be in for a patient to be taken out or put in. Once the patient is in the wheelchair, we're going to swing those leg rests forward, make sure they click in, and then we fold the foot pedals down to support their feet. When we go to get them out of the wheelchair, we fold the foot pedals up and swing the leg rests out of the way, making sure the wheelchair is locked when we put them in or take them out. Good? Yes?
Why would you take the pedals off?
Sometimes for storage, because you've got these pedals that are sticking forward. So sometimes for storage, they'll take them off. To clean the wheelchair, they'll take them off. Sometimes, I swear, sometimes people just eat them. I don't know. They just like disappear. It's very, I don't know if there's a black market for these things. I don't know, but they just disappear. But they're super important. They're way more important than most caregivers realize. All right, so we have leg rests and we have foot pedals. This is an overhead view of how the wheelchair should look at different times. When a patient is using it, the foot pedals should be down, supporting those feet. The leg rest should be forward. When the wheelchair is stored, we're going to fold those foot pedals up, but we want those leg rests locked in place. Let me show you why. If we have these leg rests like they are, open, and I close this up and I'm going to take it somewhere, do you see how these leg rests can kind of go all over the place? This means that they can hit somebody, they can damage equipment. You don't want these leg rests just flying anywhere. So if I'm going to have a wheelchair closed for storage, these leg rests need to be secured forward. But the foot pedals have to open up, because if those foot pedals are down, you can't close the wheelchair. Let me show you. If the foot pedals are down, and I try to close this wheelchair, watch what happens to the foot pedals. Well, this one slides over each other, but they get all caught up. So, stored, foot pedals up, but leg rests locked, like this. When you're transferring in or out, foot pedals up, leg rests open. Do you guys get that? This might be a written test question. it may ask you to identify what position foot pedals and leg rests might be in when you're transferring a patient into or out of the wheelchair. You would need to know which one of these to choose. So that could be a test question. This, super sad. This was a lawsuit in Georgia that occurred. And this is one of those really sad things where somebody was trying to do a good deed and it turned out very bad. So in this situation, there was a woman who was getting ready to leave a hospital. She had gone there for tests. She wasn't an inpatient. She had gone there for some tests. Her daughter brought the car to the front, and there was nobody to take the patient out to the car. No clinical staff available. So there's a clerical person, like a registration clerk or something there, had not been trained to use a wheelchair, but I mean, really, how much training do you need to use a wheelchair, right? So she sees the daughter come up in the car, patient sitting there in the wheelchair, and she thinks, well, I'm not doing anything. I'll take the patient out to the car. But she had not been trained to use a wheelchair, and she did not know to fold the foot pedals up and move the leg rests out. So the wheelchair was in this position, and she was trying to help the patient out of the wheelchair and into the car. Well, the patient's foot got tangled up in the footrests. The patient fell between the car and the wheelchair and ended up breaking her leg. So now she didn't get to go home. She got to stay at the facility. And unfortunately, this clerical person who was trying to do a good deed actually got reprimanded for using a piece of equipment that she was not trained to use. Now, we think in our minds, well, everybody knows, we can figure this out. Wheelchairs are not that hard. Remember, if you haven't been trained, there's stuff about that piece of equipment that you don't know. And the problem is that we don't know what we don't know that can put our patients in jeopardy. Good? Make sense? All right, so we're going to bring the wheelchair near the bed. We're going to get those foot pedals up and the leg rests out of the way. We're going to pivot the patient so they're in a sitting position, put their shoes on, put the gait belt on, bring the wheelchair super close and lock it. We'll have the patient put their hands on our shoulders. We're going to use that same body mechanics, 1 foot in front, 1 foot beside, their hands on our shoulders. I'm going to grab the back of the gait belt, and on the count of 3, we're going to stand. Pivot. When they say sit, because they can feel that chair, I'm going to sit them down. I'll unlock the wheelchair and spin it around, moving the leg rests and the foot pedals, supporting their feet. Lock that wheelchair, take the gait belt out, give them a call light. See ya. That's it. Good. So this skill doesn't take 11 minutes, and it's not a hard skill to do. But if you don't understand the mechanics of the wheelchair and why each part is important, you can really mess this up. Make sense? Okay. All right. So once the wheelchair is prepared, we're going to pivot the patient to sit on the side of the bed, get their shoes on. We'll bring the wheelchair close, lock it. Nope, not break, not break. Get the gait belt on, check it with 4 fingers. Make sure our foot placement is right. Do you see how close those wheels are to him? It's how close they need to be. And then we're going to help them stand, turn, and when they feel that wheelchair, we're going to help them sit. Put the feet on the foot pedals, take that gait belt off, make sure the wheelchair is locked, and make sure that they're positioned properly in the wheelchair and it's not facing the wall. That's the whole skill. Do your closing at the end. All right, so go ahead and turn this video on. And then later on, I'll pull the bed out so you guys can practice this.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good. How are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay, and I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders, maintain a wide stance, and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay, can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay, let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient, and we'll lock it into place. Okay, Mr. Jones, can you bring your feet together and slightly back? Thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gait belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock your wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
After washing my hands, I'll think about all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Right. Okay, any questions on that?
Is a wheelchair and a transfer chair the same?
In most cases, yes. There are, remember that companion chair I was talking to you about, the one with the little small 4 wheels? Sometimes that is called a transfer chair.
Because I called once looking for a wheelchair and they said we only had transfer chairs.
Yeah, there also is another type of chair that is called a transfer chair, and it's a modified shower chair. So it's made out of PVC. It has what kind of looks like a toilet seat where the patient is sitting. It's got like pool chair webbing on it, and it's designed to transfer a patient from a room into the shower room. So sometimes those are also called transfer chairs. So it depends on who you're talking to as to what, which one they're referring to. Okay. All right. So any questions on this? Any questions on this? Okay. So now we're going to go to feeding a resident in a chair. So this is on page 108. You can see all of the principles involved going down the side. They're all spelled out for you here. This is a very strange skill. because it does not follow all of our normal rules. It's very strange, and I'm going to go into each one as we go. I've got the short version. I've got a video down here. You can see test specific. They're giving you, someone with your level of experience, 9 minutes to do this. Now, when I tell you what you're actually doing, you're going to see it does not take 9 minutes to do this skill. 4 minutes maybe, but they give you tons of time here, and I'm going to explain why as we go. This is a live testing skill. So that means that you might be a patient being fed for the test. For the test, they're going to use a single serve pudding or applesauce cup. That's what they use. Single serve pudding or applesauce cup. If you're allergic to milk, you need to let them know so that they can use applesauce. If you are allergic to milk and don't like applesauce, then let them know. We don't want anybody breaking out in hives, going into shock, or throwing up during this skill. So let them know. But if you can choke down a couple of bites of something, please do so. So if you look at the top of page 109, you can see our care plan that tells us to feed the resident a snack who is unable to feed him or herself. So the patient's unable to feed themselves. We're going to give them a snack. That's going to be important in just a minute. Remember, our care plan says snack. The resident is sitting in a chair in an inappropriate position for eating. So I need you to underline that. Inappropriate position for eating. Just going to get this out of the way. We'll go on break in a few minutes. So because our care plan says that the patient is in an inappropriate position for eating, I don't care what your eyes tell you. It doesn't matter what your eyes tell you. This patient is in an inappropriate position. So when you are the patient for this skill, live patient skill, you are going to get very specific instructions. Remember, with wheelchair, we were told not to take steps. This one has a lot of instructions. The first is that you're going to eat like you eat. Chew and swallow. Don't make this harder. Be you. The second is that they're going to tell you to take 4 bites and then say you're done. No matter what somebody says, no thank you, I'm done, I'm full. Stop eating after 4 bites. So remember that this is a single serve pudding or applesauce, so we're taking 4 bites. And they're not even full spoons. We'll get to that in a minute. Okay, so 4 little bites of something. You can probably choke that down even if you don't like pudding or applesauce. Good? The other set of instructions that you get as a patient for this is they're going to tell you to sit in a chair. Come over here where you can see me. Everybody see me? They're going to tell you to sit in a chair at an overbed table, so there'll be a table there. And they're going to tell you to either slump or slouch. So now your idea of slumping or slouching might be something like this. Right? My idea of slumping or slouching is something like this. Okay, so if you looked at me like this and you needed to feed me, it would be relatively obvious that I need to sit up, right? But if the person that you're feeding is just doing this, your eyes may tell you that's not so bad. If you've ever eaten with a 10-year-old, they all do this when they're eating. This is not an appropriate position for eating, guys. Patient needs to be sitting up. So it doesn't matter what your eyes tell you. Is this patient sitting straight up? According to the care plan. So we need to get them sitting straight up. And to do that, we just ask them, hey, can you sit straight up? Can you sit straight up? Good? Make sense? Okay. So for this skill, it does not matter what your eyes tell you. Your care plan is what we're going to go by. Then it tells us to document the intake on the food and fluid intake form. So if you go to page 169 for me, you can actually see these forms. So on page 169, we got a small version of it here on this page. But on page 169, you can see the food and fluid intake form. Now, if you remember, our care plan told us that we're feeding the resident a snack. And on page 169, you have to mark off whether you're feeding them a meal or a snack. Which one are you going to mark? Snack. Because it comes right off the care plan, guys. Good? Make sense? So over here on page 109, you can see how to fill this out. You're going to see this again in just a few minutes. But feeding does not follow our normal patterns, our normal rules. And the way this is a little bit different is we're not going to use a barrier on our table because our food tray is the barrier. Now, in your practice kits, you actually have a little food tray. So you can go home. This is one of those skills that you really can practice at home if you've got a live human laying around. Go grab a pudding or an applesauce or something. Go grab something, bowl of ice cream. You can usually get somebody to cooperate. And put it on your little food tray with a spoon and a napkin and a cup of water and take it over to your live human and say, hey, I'm going to feed you. You can practice this at home. So we don't use a barrier on the table. Our food tray is the barrier. We also don't close the privacy curtain for this skill. It's the only skill that we don't close the privacy curtain for. And that's because eating is a social event. Most people gather in groups to eat. You have conversations. Imagine for a second going to a restaurant and there's like 60 people in there in the restaurant. But when you walk in, it's dead silent. How weird would that be? Right? We don't expect that in an eating establishment. We expect conversation. That's because eating is social. Does that make sense? No, we don't talk with our mouth full. But you might say something while I'm chewing, and when I'm done chewing, you take a bite and I respond. Eating is social. And it's not just that eating is social, eating forms the foundation of all social engagements. Baby showers, there's always food. Weddings, there's an elaborate menu of food. Graduations, there's food. Birthday parties, there's food. Even funerals, there's food, right? So eating becomes the very foundation of our social experiences. That is important. If eating and socializing are that closely tied, what do you think we need to do when we're feeding a patient? Talk to them. Socialization is part of this skill. Does that make sense? It's the only skill where you're required to have a conversation. Every other skill, we can get away with telling them what we're doing. Okay, I'm going to unfold this towel. I'm going to put your hand in the basin. You can tell them the steps. That's fine. I don't care about the other skills. You can't do that with this one. If you say, okay, I'm going to get some food on the spoon and I'm going to bring it to your mouth. Weird. No, we're not doing that. We need to have an actual conversation here. Now, the conversation doesn't need to be real. You can make something up. You can talk about a football game. You can talk about a movie that's going to be playing on the big screen later. You can talk about the weather. I mean, this is a big topic. I guarantee you, in most institutions, this weather is what's being talked about during meal times. It's a big deal. You can talk about real or not real for the test. Nobody cares, but you do have to talk. But it's not just you have to talk, it's that you have to talk in the right way. If I'm going to feed you and I'm standing over you talking, is this comfortable for you?
No.
No, because we are at a completely different level. By standing, I'm actually looking down on her, not just physically, but figuratively as well. In order to feed somebody, you have to be at their level. Does that make sense? This is the only skill where you are required to sit. So we don't close privacy curtain. We don't use a barrier. We have to have a conversation, and we have to be sitting while we feed a patient. This doesn't follow any of our rules. Good? Make sense? Do you understand why? Okay. All right, so for the test, we're going to ask our patient to sit up straight. It does not matter what your eyes tell you. Ask them to sit up straight. Once you get them sitting up straight, we're going to offer a hand wipe. Even though I'm feeding them, it doesn't mean that they're paralyzed. There's nothing in that care plan that said they were immobile. Nothing. Just said they weren't able to feed themselves. So if I get food on their chin, they might bring their hand up to wipe it away. It doesn't, remember, never add something into a care plan that is not there, right? So we're going to give the patient a hand wipe. That way they have clean hands while they're being fed. But it also goes to ritual because most people wash their hands before they eat, so it stimulates the appetite. We're going to offer a clothing protector. We do not call them bibs. These are not children. We're going to offer a clothing protector. If the patient says no, no problem. If the patient says yes, we'll use it. Me, I need a clothing protector. I wear everything. I need a clothing protector. My grandmother, if you offered her a clothing protector, she would look at you sideways. I am not a child. Right? We're all a little different. Does that make sense? So we're going to offer, but we will take their lead. We have to sit while we're feeding the patient, and we're going to offer a drink before we feed them and every 2 or 3 bites. Do you remember how many bites I told you the evaluators are going to tell you to take? 4. So we're offering a drink every 2 to 3 bites. If we get to bite 4 and you haven't offered a drink, you don't get that checkpoint. That's why they say 4. There's a reason. Good. Now, talk about drinks real quick. Everybody has different preferences here. Everybody. So I don't have a lot of saliva. I don't create a lot of saliva. So when I'm eating, I have to drink while I'm eating for the food to go down properly. This is also why I have a drink here, because my mouth dries out so quickly. So I drink while I'm eating. I drink before, during, and after. I'm drinking all the time. Now, my husband doesn't drink while he's eating. He wants the food to fill him up, not the fluid. So he doesn't drink while he's eating. He drinks after he eats. Now, my aunt, on the other hand, she had been a model early in life, and she was taught very young that you drink an entire glass of water before you eat anything, and the water fills you up and you eat less. And this is how she kind of kept her figure throughout her lifespan. It does not work for me. I've tried it. It does not work for me, but it worked for her. So she would drink an entire glass of water before she ate anything. Make sense? So we've got 3 different people, 3 totally different eating strategies. Which one is your patient going to use? Say it out loud. We don't know. How do we know? We ask them, do you want a drink? Before we feed them, every 2 or 3 bites while we're feeding them, and after we feed them, because we don't know. Make sense? Okay. We're also going to ask them, what do you want first? What do you want next? Now, for the test, we're just giving, it's just one food item. There's no first, second, third, But if you are feeding somebody a meal, don't assume that they eat the way you do. Everybody eats different. Some of you eat all of one thing on your plate before you go to the next. Some of you graze a little here, a little there, a little this, a little that. Some of you eat your salad first. before the meal. Some of you eat the salad after the meal. Some eat dessert first because life is short. Some eat dessert last if they have room. Some people like their corn and mashed potatoes mixed. Other people don't like their foods to touch at all. You don't know how your patient wants to be fed. This is a skill that we have to get to know our patients, and we have to ask them as we're feeding them. So I'm going to give you an example of this. I laugh every time I think about this. Poor patient. Many years ago, I was a hospice nurse, and I went into facilities as a hospice nurse, and I was caring for a patient who had had a stroke, and she was nonverbal and paralyzed on one side and very weak on the other, so she had to be fed. She was actually terminal cancer on top of that, right? So stroke was kind of secondary, but it affected her, so she had to be fed, and she couldn't really talk much. She could grunt and make noises. You got to know her a little bit, and you could kind of figure out what she was trying to say. Well, I go into the facility to see her, and she's in the dining room. So I go down to the dining room, I pull up a chair, and we're going to call her Mary. Hey, Miss Mary, how are you today? And I look at her plate, and it's this big gray glob of something on her plate. I'm like, ugh. What is that? And I asked the CNA, what is that? She says, it's lunch. I said, okay, but what is lunch today? She says, Salisbury steak, mashed potatoes, and beets. And I said, okay, but what is that? And she said, Salisbury steak, mashed potatoes, and beets. I said, together? She said, well, yeah, it's pureed. Nobody cares. You know, there's no taste to it. You just mix it all together. I said, would you eat Salisbury steak and beets mixed together? She says, oh, God, no, that's gross. Pureed does not mean no taste. Pureed means no chew. All the taste, different texture. So when you mix pureed stuff together, they're getting that mixture of tastes. Don't do that to your patient. I made that CNA go get a new tray, and then I fed her. But the patient was trying to tell the CNA. She kept turning her head away and rolling her eyes away when the CNA was trying to feed her. And the CNA just kept yelling at her, look at me, turn toward me. Wasn't understanding that this patient is trying to communicate that this tastes like crap. So we have to make sure that we're watching our patients that can't communicate verbally and trying to figure out what it is they're trying to convey. Does that make sense? Did you guys see? Oh my gosh. Did you guys see the CNA that was dancing on a patient's head? Did you guys see that? It came up this morning. Yeah. Oh my gosh. We got to get... Professionalism is needed in this industry, guys. Like, professionalism is really needed in this industry. Yeah, go find it. It'll be somewhere on the internet. Unbelievable. Unbelievable. All right, so we're going to offer drink before feeding. We're only going to fill the spoon half full. Little bites, little bites. So 4 half full spoonfuls is all you're going to be eating. Remember I said they gave you 11 minutes to do this? And I told you eventually I'd tell you why you don't need 11 minutes. 4 half full spoons. This does not take 11 minutes, guys. We're going to have a conversation. Nobody cares what you say. Just say something. And then when the patient says, I'm done. So they're going to take 4 bites. They're going to say, thank you. I'm finished. I'm full. I don't want any more. Your job is to encourage them. They're looking to see, are you going to say, oh, thank God I got stuff to do? Or are you going to encourage the patient to eat? Now, there's a reason for this. This is psychology. Eating is the very first skill you become independent at. Very first one. You learn how to hold your bottle long before you're sitting, standing, crawling, or walking. You learn how to pick things up off a high chair tray and get them to your mouth before you can even sit. You feed yourself before you can recognize what hunger even is. So eating is the first thing that you become independent at. And once you become independent, you don't want anyone to feed you. You do it yourself. We are fiercely independent with feeding. Do you guys understand the psychology there? So when you are impaired to a point that someone else has to feed you, it affects you psychologically in a very big way. So if you're feeding somebody and you're rushing through it, they're going to stop eating. If you're feeding somebody and you're paying attention to something else, they're going to stop eating. If the patient can feed themselves, they will. And a lot of times we have adaptive equipment to help them with that, or finger foods, small sandwiches cut up. We encourage the patient to do as much as they can for themselves, especially with feeding, because patients that have to be fed generally have poor nutrition. Make sense? Good. So the way we approach this is super important. You need to act like that patient is the most important thing in your life at that moment. And you are absolutely invested in them. Otherwise, they're not going to eat. They just won't. We had a lady that I was caring for in a nursing home. And this is where you've really got to trust your CNAs as nurses. You really have to be able to trust your CNAs. I had a patient who the CNA just kept putting refuse. I mean, she just wasn't eating. And she was down to like under 80 pounds. So I was walking by the room while the CNA is in there. And the CNA is standing next to the bed, standing. The TV is on. Some sort of, I don't know, stupid show, right? Not something that an older person would generally choose to have on TV. Drama-filled young people show. And the CNA is standing there. The TV is on the wall here. The patient is here doing this. Come on, hurry up. You done? Now, I knew immediately why this patient wasn't eating. So I told the CNA to go do something else. I was going to take over. And I talked to her after. I will never, ever yell at you in front of other people. But when you disrespect my patients, God help you when I get you alone. I sat down, pulled up the tray, and I said, oh, man, I have been running my tail feathers off. Do you mind if I sit? You mind? Can you eat slow for me? I need to be here a few minutes. She took a couple bites and she goes, oh no, you got so much to do. Just go, it's fine. And I'm like, don't make me get up yet. Take a couple more bites for me, would you? I got to rest my feet. She ate that entire tray. The entire tray. So her malnutrition had nothing to do with her. It had everything to do with the staff that was feeding her. Guys, we have the power of life and death in our hands every day. And the way the patient reacts is going to depend on the choices that we make. And this is why professionalism really needs to make a comeback. This is why I spend so much time talking about this with you. It's not just about the test. It will never be about the test. It will always be about the patients that you care for after the test. Good? So we're going to ask. We need to use 2 forms of encouragement for the test. I use 3. You can take 2 out of them. Are you sure you don't want just one more bite? You can get a lot further with patients by being nice. Please, for me, just one more. Second thing I ask is, would you like something else? We've all had those days where we thought we wanted something, we went and got it, we took a bite, and it's like, nope, not it. Not what I was looking for. Maybe your patient's having that day, and they're just afraid to ask for something different because they don't know the rules. So I'll ask them, would you like something different from the cafeteria? Maybe this isn't it, you know. The third thing I'll do is tell them, if you get hungry later, let me know, I can get you a snack. That way they know that food is available and I'm willing to go get it for them. It's not an inconvenience. You need to use 2 of those. I don't care which 2, pick 2, but you need to use 2. We're going to leave the patient's mouth clean, just like mouth care. So use that clothing protector and wipe up their mouth. And we'll do the closing. Now, I do want to talk about gloves really quickly. We are on the other end of a spoon. Unless your patient is unable to control saliva, you don't need gloves for this skill. You are on the other end of a spoon. You've washed your hands before, you'll wash your hands after. If you wear gloves for feeding, gloves give off an odor. That odor is an appetite suppressant. It will kill an appetite. Wear gloves when you need to, but this is one of those skills that if you don't need them, please don't wear them. They do more harm than good. But they also, again, psychologically, what kind of signal do you think that sends to a patient that you're feeding?
Makes me uncomfortable because you are like scared to feed them.
That's right. That's right. They feel like they are inferior, that they have something that you don't want to catch, that they're tainted in some way. Make sense? The things we do matter, guys. They matter. So at the end of the skill, we're going to document on the food and fluid intake sheet. We're going to put that it was a snack because that's what our care plan told us. We're going to check off how much the patient ate based on a percentage scale. And we're going to mark off how much they drank based on a percentage scale. Now I'm going to tell you how to answer this one. It's always 25% for the test. Always. You are giving 4 half-full spoonfuls. That is about a quarter of an applesauce or pudding cup. Good. Now, liquid, it depends on what they drink. If they drink all of it, they drank 100%. If they drank none of it, they drank 0%. If they drank half of it, 50%. A little more than half, 75. A little less than half, 25. It's based on what the patient consumed. And I don't know what your patient is going to consume for the test. They might be nervous and really thirsty. All right, so our details matter here. We're going to offer a hand wipe, a clothing protector. We're going to offer a drink before feeding and every 2 to 3 bites. We're going to let them lead, feed them slowly, spoon only half full. And we don't use childlike feeding techniques. No planes, trains, or automobiles. I will tell you that in a clinical setting, you will find those that you can play around with. Humor does work. But you've got to use it on the right people. I have absolutely used airplanes and race cars on some patients because it gets a laugh. I would not do that on my grandmother. She is prim and proper, and that would not be acceptable. So you have to know how to read your patient. But for the test, we're not doing that. We're remaining professional. So let's talk about feeding percentages. So for the test, we're going to use a percentage scale. In most settings, you would use a percentage scale as well for food. Fluids are often computed more specifically, but feeding is always done on a percentage scale. So 100%, they ate it all. Clean plate club. Good job. 0%, they refused. The tray went back to the kitchen in the same way it came out. In between, well, if they ate half, they ate half. This is not a precise science. We don't have to like count the peas and make sure that they ate half. It's a guesstimation. Okay, if they ate about half, give them 50%. If they ate a little more than half, but not the whole thing, give them 75. So we're going to guesstimate here. So if you look at this graphic here, you can see that this is what we started with. We had a sandwich, some broccoli, and some Jell-O. This is the tray that we picked up. How much do you think out of that, that's what we started with, how much do you think we should give them credit for? 25%. What about this one? About 50%. Yeah, that's about half. Yeah, what about this one? 75. Yeah, what about this one? 100. Sure, that broccoli stalk doesn't really count. Okay. It's closer to 100 than it is 75. Make sense? Okay, so in your book on page, where am I here? 106, thank you. 106 is a feeding documentation activity. So this lesson explains what I just explained to you. So if you look at the first column, toward the bottom of the first column is an activity. We've got 2 eggs, 2 pieces of toast, 3 slices of bacon, and some cantaloupe. And boy, does that sound good right about now. You want to go to let's go grab some lunch. All right, when we go pick up the plate for number 1, how much do they eat? 100%. Absolutely. What about number 2? Yeah, 50%. We got 1 egg left out of 2, 1.5 slices of bacon out of 3, 1 slice of toast out of 2. So yeah, about half. What about number 3? 75. Now 4 is a little tricky. Look close. Look close. Yeah, 25%. Most of that bacon is gone. Some of the toast, a little bit of the cantaloupe. They didn't touch the eggs. So about 25%. It wasn't a refusal. They did pick at it, but that's nowhere near half. Make sense? Good? All right, so fluid intake is often computed more specifically, more scientifically. And to calculate fluid intake, we often have to convert ounces to cc's. So in most cases, take this to show you. In most cases, if you have a prepackaged item, prepackaged, on the label, it's going to tell you how many ounces, and right next to it, it tells you how many mLs. mLs and cc's are the same thing. Same thing. 2 names, same thing. There's actually a little bit of a difference scientifically. We're not going to get lost in the weeds here. For our purposes, mLs and cc's are the same. Good. So if you look at this here, this measurement, it tells us this bottle is 20 fluid ounces. Now, right next to it, luckily for us, it gives us how many mLs. And this is 591 mLs. Now, your water bottle, if you look at it, should be, yep, and right next to it, it should say 500 mLs. So the good thing about prepackaged items is it's going to tell us our mLs. We don't have to do a conversion. The problem is that not everything that we use in a clinical setting is prepackaged. We're going to use cups, like water cups, juice cups, coffee cups, and we have to know, okay, how many ounces is this cup? And then we have to convert that to cc's, mLs. And the way we convert it is every ounce is equal to 30 cc's. So if I have 1 ounce, that's 30 cc's. If I have 6 ounces, I'm going to multiply 6 by 30 and get 180. So we multiply the amount of ounces by 30 to get our mLs. Make sense? You will have a math question on the state exam. That math question is either going to have you convert ounces to cc's, or it's going to ask you to add up the amount of cc's that the patient took in that shift to get our total intake. So you will either have a multiplication question or an addition question on the state exam. So if you look at the bottom of page 106, second column, you can see that we have 6 ounces of juice. How many cc's would 6 ounces of juice be? 180. So go ahead and write in 180. We have 8 ounces of milk, but remember it's prepackaged, so we can look at the carton. So what does our carton tell us for mLs? 240. And we have 12 ounces of coffee. Guys, that's a lot of coffee. We have 12 ounces of coffee. So 12 times 30 would be? Not quite. 360. That's right. So that's how you do conversion. So you might have a question on the state exam about that. How do you do conversion? Now, at the end of the shift, we're going to add all of that up. We're going to add the 180, the 240, and the 360 up. And that gives us our total intake for the shift. So can anybody add those together? 180, 240, 360. What is it? 780. 780 mLs. So you will get one of those 2 types of math questions. They'll either ask you to convert or they'll ask you to add it all up for total intake. That's what you see here on page 106 for those of you who are playing along at home. I've got a whole lesson on intake and output there on page 107. And it will explain everything I just talked to you about. But while we're on the subject of activities, let's talk a little bit about medical abbreviations. So this is on page 132. There aren't very many medical abbreviations on the state exam. There are very few. The ones that might be on the state exam are highlighted in gray. So anything that's highlighted in gray, I would make sure that I knew before I went to the state exam. For instance, what does CNA stand for? Yeah, if you're going to be one, you probably ought to know what it stands for. What does RN stand for? Registered nurse. So some of these you already know. But let's talk about the ones over here at the very, very top, because these mess you up big time. The biggest thing that you need to understand about medical abbreviations in healthcare is that most of them are not abbreviated English. They're abbreviated Latin, because Latin is the language of science. So when you look at that first one, PRN, it actually means as needed. Well, how does PRN mean as needed? I mean, those just don't go together. Well, PRN is abbreviated from Latin words. Prore nata, I think it is, that means as needed.
What's the difference between just a nursing assistant and a certified nursing assistant?
Certified means you've been tested by the state. Nursing assistant means you haven't been tested by the state. That's the only difference. Only difference. So when you look down a little bit further, you see BID, TID, and QH. Again, this is abbreviated Latin, but let me demystify this for you. B stands for bi. How many wheels does a bicycle have? 2. So BID means 2 times a day. T stands for tri. How many wheels does a tricycle have? 3. So TID means 3 times a day. Now QH, Q actually means every. When you see Q, it means every in Latin. QH, every hour. Q2H would be every 2 hours. Q4H, every 4 hours. So if you understand that key, all of this is easy. Makes sense. I want to go back up here and talk about PRN though. We're going to talk about this a little bit more next Wednesday. But you will often be offered a PRN position when you first start in healthcare. Generally speaking, healthcare does not hire full-time right out of the gate. They don't know you. And they have to jump through a lot of corporate hoops to fire somebody. It takes so much work to fire somebody. So in healthcare, they often won't hire you full-time right away. They will give you a PRN position. Now, it's not on call. What it means is truly as needed. So you tell them, hey, I can work on Tuesdays, Thursdays, and Saturdays. And they say, okay, we'll put you on the schedule for Tuesdays, Thursdays, and Saturdays. It's as needed. You are not working full-time. You do not get benefits, but you do get a higher rate of pay. Offset. But what it is really is an extended interview. If you show up on time, if you treat the patients well, if you get along with the other people that you work with, if you respect the nurses and they respect you, you will get a full-time position when one comes available. So don't dismiss PRN positions. It's actually a way for them to try you out. If they don't like you, they just don't put you on the schedule. Oh, no, we didn't fire you, but you're not needed. We don't have any shifts available for you right now. It's a way of them being able to refine their staffing without having to go through a lot of legal hoops.
And can't you sign up somewhere and go to different facilities?
Okay, that's agency. That's different.
But you can sign up for PRN and then maybe decide where you would like to work for them.
So agency is a little bit different. Agency, think of an agency like a substitute. When you were in school, you got substitute teachers. They didn't work at that school. You know, they would go to different schools. They would just fill in for teachers that couldn't show up that day. An agency worker is exactly that. It is a substitute worker. An agency worker, you're sent to a facility for one shift. You get a higher rate of pay. It's a win-win. But there's some problems with agency. Actually, there are a lot of really big problems with agency, and most of them boil down to the patient. But let's talk about the facility first. If you work at a facility and you work at the same facility, but you can't come in today, I'm going to ask you, do you want to pick up her shift? I'll give you a little extra money. I'll pay you an extra $100 if you come in and cover her shift. That works well for you. You pick up her shift, everybody is happy, the facility is happy. But let's say that I ask you, would you like to pick up her shift? And you say, no, I've got something going on. I can't. Well, I've got to have somebody there. I need a worker. If I don't have anybody in my facility to do it, I've got to call an agency. Hey, I need a worker for this shift. And the agency picks you. Hey, we got an opening here. You want to go? Now, the facility is going to have to pay that agency a ton of money. Way more money than if I had somebody from my staff do this. So if a facility has a lot of agency people in there, what kind of a budget do you think that that's going to require? A lot, which means when it comes time for your review, there may not be any money for a raise. Remember that facilities have to operate on a budget. It's not an unlimited open bank account. They have to be able to operate on a budget. So it is better for a facility to develop a strong staff than hire agency. But there's a problem with the patients too. You know the patients. You work there. You know the patients. You work there. If you cover for her shift, you still know the patients. You know what they need, how they act, you know where to find the supplies. Everything works well. You've never been to that facility a day in your life. You don't know where to find the washcloths. You don't know the patients. You don't know who likes what. But the most important thing here, the real problem here is that half of our job is observation, right? Half, that's what sets us apart from every other type of caregiver. Observation and reporting. That's what makes a CNA a CNA. If you don't know the patients, you're not making observations. So we've got a lot of things that are getting missed. So it's costing the facility more, but more importantly, it's costing the patients. So most facilities are now trying to get away from agency because it is a bad proposition all the way around. Does that make sense? Okay. Now, during COVID, agency was really big, and they had travel CNAs for the first time ever. Indiana would say, hey, I'll pay you $30 an hour if you come, because they just didn't have enough staff in their local area, and the patients have to be cared for. So this opened up a brand new industry called travel CNAs, and people would go to Indiana and North Dakota and New York and all of this. You'd get a 13-week contract. You get paid really good money, but the patients are the ones that actually suffered in that. We had a much higher death rate. So they're trying to pull back from that a little bit. Make sense? Okay. So yeah, you can still find some agency and some travel, but they're really cutting back on that, really decrease. Their goal now is to develop really good, strong in-house staffing. And that's really the way it should be. But when you're looking at this page here, about 3/4 of the way down the first column, you'll see something called NPO. Now, NPO, again, is abbreviated Latin. Abbreviated Latin doesn't mean anything in English, so don't try to make it make sense in English. It means nothing by mouth. Nota per ora or something like that, which I don't know Latin, but it means nothing by mouth. So if your patient is NPO, are we feeding them? No, it's nothing by mouth. You need to know that term, NPO. Let me tell you a funny story about this. Oh my gosh. So we owned the scrub shop, the retail store, and we just closed it in December. We're the only scrub shop in the county. Well, because we're the only scrub shop in the county, everybody shopped with us. And when I was standing behind the register, a lot of times I would talk to nurses and stuff. And one girl came, this is about, 8 years ago. One woman came in and she says, hey, you teach CNA class, right? And I said, yeah. She says, I got a story for you. This is something you can pass on to your students. Okay. So we're going to call her Kathy, Nurse Kathy. And Nurse Kathy worked in the cath lab, the cardiac cath lab. So she worked directly with the doctor. They did cardiac caths, opened up arteries. It's a very intensive area. So it's 5 o'clock in the morning. She goes upstairs to get a patient for their first heart cath case of the day. Doctor is scrubbing in downstairs. So Kathy goes upstairs to get the patient who should have been NPO, nothing by mouth. They're about to have a surgical procedure done. She walks in the room and the patient is sitting up in bed eating. So she goes and the conversation was, this is how it was reported to me. I asked the patient, what are you doing? He says, I'm eating. She says, I can see you're eating. Why are you eating? You're about to have a procedure. He says, I didn't think I was supposed to eat, but the girl brought this tray in and said that I had to eat it before I went. So Kathy goes to find the nurse responsible for that patient. What's going on? Why are they eating? And the nurse says, oh, I don't know. That one has a student nurse. Let's go find the student nurse, find out what's going on. So they go find the student nurse. And this is the conversation as it was relayed to me. Okay. So I'm going to play both parts, but this is the conversation that she told me she had with a student nurse. Kathy goes up to the student nurse and says, the patient's getting ready for a heart cath. Why are they eating? Student nurse says, because they're NPO. Kathy says, I know they're NPO. Why are they eating? And the student nurse says, because they're NPO. Kathy says, what do you think NPO means? Student nurse says, and I swear this is true, Nana's, pineapples, and oranges. I went and got the tray myself from Dietary. Kathy's like, NPO does not mean Nana's pineapples and oranges. Nana's isn't even a word. But now we've got a patient who's not getting a heart cath. We got a doctor who has scrubbed in and is now standing there with nothing to do. You think that made him happy? He's losing money. And we've got a student nurse that had no idea what NPO actually meant, so she made something up. If you don't understand what a medical abbreviation is or what a term is that somebody used around you, do not try to make it up. Ask. I don't care how stupid you feel. Ask. I'm so sorry. What does NPO stand for again? I don't remember. I'm so sorry. That would have been way better than going to a cafeteria, asking them for a tray of Nana's pine. And I can't even imagine what that cafeteria thought. Yeah, Nana's? What is that? I mean, Nilla wafers would have been better. You know, it just, don't make this up. Make sense? Oh my gosh, what a story. I really feel bad for the patient though. They need a heart cath and they got to wait. Plus, they had to eat Nana's pineapples and oranges at 5 a.m. All right, so this is our documentation form. This is for food and fluid intake. This is for intake and output. So you can kind of see what they're going to look like. And I've got a whole lesson on this for you. Let me show you this video, and then we will take a break. The last skill we're going to do today is Peri Care. I've got a little bit to tell you about that, and then you will have practice time in class today as well. Yep.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me
Thank you.
dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Okay. Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate. Using my documentation form, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on that? Any questions? Okay. Let's go ahead and take a break. All right, we are back from break. This is our last skill for today. You will have some practice time after this today. But the skill itself is not hard. You already know everything you need to know to do this skill. You know how to do this. The problem is that you probably don't know why certain steps are going to be important. And that's what we're going to cover now is a brief review of the urinary system, particularly the female urinary system, although both are the same. But we're going to focus on female. And the reason that we have to go over this is because of infection control. So we're going to talk about this briefly. We will talk about the steps of Peri Care. I will show you the video and then we'll open it up for practice. So page 152, these are all the principles involved. And like partial bed bath, we're using almost all the principles. So there's a lot of similarities between partial bed bath and Peri Care. It's just where we're washing is different. But if we're washing a wet body opening, we still have to use that leaves method. So there's going to be a lot of overlap between these two. And the biggest thing that I want you to understand is you already know all of these steps. So because our patient is uncovered and undressed, what do we need to use? We're going to be working around wet body openings. So do we need gloves? I need supplies. So what do I need to have on the table? A barrier. When I wash the patient's backside, I've got to turn them on their side. So what do I have to do first? Scoot them toward me. Whatever I wash, I rinse. Whatever I rinse, I dry. Who has to check the water? Yeah, us and the patient. Yeah, everybody. Everybody gets to check the water. All basins are going to be cleaned the exact same way. We're going to do our closing. I mean, you already know all of this. There is nothing here that should be, oh, I wasn't expecting that. You know the steps. But we have to talk a little bit about incontinence because that's really what this skill is all about. Our care plan at the top of page 153 says the female patient has been incontinent of urine and needs perineal care. This is often shortened to Peri Care, but the term is perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. Guys, I'm telling you, this is a miracle. It never happens like this. If the pad under the patient is wet, so is the gown. We're probably going to change it. But for the test, this is a mannequin skill. Your mannequin is going to be dry. This is a simulation. Make sense? Simulation. All right. But let's go back up to the top here. It says the female resident has been incontinent. For the test, we are going to demonstrate this on a female mannequin, not a male. And that's because the infection risk is much higher in females. The urethra, or the tube that leads from the bladder to the outside world, in a female is only about as long as your pinky. That's it. That's not very far for bacteria to travel. That's like a day trip. So when we're wiping females, the way we wipe actually matters. We're going to use that leaves method, but the direction we wipe is going to matter. Now, male Peri Care, you're going to clean the male genitalia. You'll start at the top, go down the shaft, clean the scrotum. This is very quick. Whatever we wash, we rinse. Whatever rinse, we dry. I have specific instructions on male Peri Care. Hold on. On page 154. We'll talk to you about male Peri Care. Haley says, guys, I just wanted to join and say I passed most of the exams last night. Oh, congratulations. That's amazing. We're super proud of you. All right. So page 154 will tell you all about male Peri Care. But for the test, we're going to focus on female. The mannequin will be female. This is a mannequin skill. The evaluator is going to speak for the mannequin, so you will talk to the mannequin. You will get an answer. But it's going to be a female. A lot of supplies, guys. That's where the flashcards are going to come in handy to help you memorize those supplies. So let's review. This is a 5th grade review of the urinary system. You've got 2 kidneys. Most people are born with 2 kidneys. Those kidneys work 24 hours a day filtering your blood. They never take a break. There's no time off. There's no coffee breaks. Your kidneys work constantly, filtering all of your blood and pulling out waste products. It makes urine from that waste product. That urine drip, 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 drip out of the kidneys as the urine is produced. Now, it's not convenient for us to be dripping all the time. So we have a bag. That's all a bladder is. It's a bag that's going to hold all of those drips until it gets full. When it gets full, it rings a little bell in your brain, says, hey, we're full. Go find a bathroom. You go to the bathroom. And there's a little valve down here at the bottom of the bladder that opens and allows the urine to come out. When you're done urinating, that valve closes. And that's what closes up this bag, is this valve. Everybody good? Make sense? Males have the exact same system. Everything is exactly the same. It's just their urethra is a little bit longer. But everything else is exactly the same. Now, why do we care about this? When we are incontinent, that same system still works the same way. Still have 2 kidneys. They still filter blood, produce urine, drip, 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 24 hours a day, never, ever stops. Those drips go down ureters into the bladder. What is broken when you're incontinent is that valve. So what happens to those drips? They come out. So incontinent patients are going to be wet all the time. Drip, 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 drip. You're going to clean them up and drip, drip. They're going to be wet again. If you have a patient who is dry, 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 really, really wet, they are not incontinent. What you have is incompetent staff members who are not taking that patient to the bathroom. And this is a real problem out there. A lot of CNAs will tell patients, adult patients, just go, I'll clean you up later. It's easier. Would you guys be comfortable if I told you, yeah, we're not going to use the bathroom today. It's too much for me to try to clean. Just pee your pants. We'll clean it up later. I mean, would you be comfortable with that? Absolutely not. And yet caregivers are doing this to patients. We don't do that. If your patient is dry, 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 that valve works. Get them up to the bathroom. Now, this is such an issue out there that there's an agency that oversees all hospitals, nursing homes, all facilities, right? It's called the Joint Commission. And they come and they do what they call surveys, their inspections. And if Joint Commission comes and they look at all the charts and a patient was admitted continent, and while they're here, they become incontinent, and there's no medical reason for that to happen, we know that's a staff problem. And they will fine that staff, that facility, $10,000 per occurrence. Per occurrence. What do you think is going to happen to your budget, your paycheck budget? Yeah. So this affects you. This affects you monetarily. Don't let other CNAs get away with this. It's bad for the patients. Does that make sense? The good news, the really good news, is that this is a muscle. So if I'm sitting on the couch and I'm not doing anything, I'm not up moving around, right? My muscles are going to get all flabby. They're just not going to work very well anymore. But if I get up off that couch and I start taking walks and I start lifting weights, what happens to my muscles? They get stronger. They start to work again, right? This is a muscle. If we have an incontinent patient, we can help that muscle get stronger again by taking the patient to the bathroom on a schedule every 2 hours and before meals. You put a patient on a schedule. That means we got to get them up at 2 a.m. and take them to the bathroom. We got to get them up at 4 a.m. and take them to the bathroom. You get them on a schedule and that valve starts to work. And as it works, it starts to get stronger. And before you know it, now our patient is not incontinent anymore. And that's a win for them. So a lot of your patients are going to be on a toileting schedule, and that's what it means. Good? Well, let's talk about patients that are incontinent. So an incontinent adult is not like an incontinent baby. Incontinent baby, right? They don't know how to use the bathroom yet. They're not potty trained yet. So they have a diaper on. We don't call them diapers for adults. They have a diaper on. You put a diaper on a baby, you put them in bed and let them sleep 8 hours. You wake up, they still have skin on their little tushes. It's okay because their urine is very mild. Urine acidity is directly related to what we eat and drink. Babies eat and drink very mild things like milk or breast milk or cereal or baby food. It's all very mild, not acidic at all. Not acidic at all. So they can sit in urine with, in the diaper all night and it's not going to eat their skin. Adults, everything we eat and drink has acid in it because it tastes good. So when this adult is incontinent and they're laying on urine, that urine is acidic. What do you think that's going to do to skin? Yeah, it breaks it down. It burns the skin. And this patient is at risk for bed sores. Make sense? Good? So adult urine, not like baby urine. So we can put a baby to bed, let him sleep all night. We can't do that with adults that are incontinent. We have to change them and clean them every 2 hours around the clock. So if we're already waking them up to clean them and change them, let's get them to the bathroom. Make sense? If they're in bed, we're going to use adult briefs. We don't call them diapers. Some people call them depends, and that's fine too. Adult briefs. This is something that goes on, holds the urine in. But there's some problems with this. If the patient's out of bed, this is a dignity issue. They need an adult brief on. Nobody wants to wet themselves in public. That's a dignity thing. But that adult brief is going to hold that urine right up next to the skin. What do we know about adult urine? Yeah, acidic. So we're going to have some skin issues here. It's going to hold the urine right against the skin. But it also blocks out light. So now we got a dark area. And it's going to hold in body heat. So we got warm, dark, moist, and acidic. This is like the ideal breeding ground for everything bad. Everything. So when we change an incontinent patient that's wearing an adult brief, you better make sure you get that skin super clean. Make sure you're rinsing well to reduce that, acid from direct contact in the skin. But if the patient is out of bed, that's a good strategy because nobody wants to wet themselves. When they're in bed, though, there is a better option. A patient who is incontinent in bed, we can put them on a chucks, a barrier, an under pad. And if you put an adult patient on an under pad, that allows that urine to get pulled away from the body. So we have less direct skin contact. It also lets light and air circulate. So we have fewer infection risks. So if they're in bed, having them on a pad open to air can actually reduce skin issues in incontinent patients. Now, not everybody is comfortable with this. Some patients want an adult brief on. That's something that the nurse would find out during her assessment, and it would be reflected in the care plan, which gives us specific instructions. This patient is open to air on a pad, which is best practice. Make sense? Good? This absolutely can reduce skin issues and infections. But let's think about that pad for a second. Anybody remember what body temperature is? Yeah, 98.6. Let's just go with easy numbers. Let's do 98 because it's a range. 97.6, 99. Let's just use 98. Easy. I like easy numbers. Room temperature somewhere around 72. 73. If you like it warm, 75. Let's do easy. I like easy numbers. So let's say body temperature is 98, room temperature is 75. Good? Everybody with me? The urine that comes out of the body is actually warmer than body temperature because that urine is in your bladder right up next to your furnace. Remember we talked about burning calories, generating heat. So that urine that comes out is somewhere around 101 degrees when it comes out. That's warm. Now, as that warm urine spreads on this pad, it encounters room temperature air. What do we know about room temperature? 75, but what does room temperature always do? It wins. Room temperature always wins. So that urine that's spreading out on that pad is going to cool down to room temperature. What do you think that pad now feels like to that patient? Cold, wet, and probably a little slimy. Yeah. So are they comfortable on that pad? What do you think the very first thing they're going to want done is? Change that pad. But we got a wet butt on a clean pad. So we're going to change the pad. We're going to clean the patient front and back, and then we're going to change that pad again. So at the end of the skill, we have a clean butt on a clean pad, and we're ready to go for 2 more hours. There is a possibility in some patients that your care plan may have you do this every hour if our patient is particularly vulnerable. We always go by our care plan for that patient. But general standard is every 2 hours around the clock. So cleaning is going to follow all of our normal cleaning processes, right? We're not going to add soap to the basin. We're going to use a paper towel to get the water. We're going to check it. It should feel warm. We're going to let them check it. Whatever we wash, we rinse. Whatever we rinse, we dry. If the water gets cold or soapy, we'll change it out. Don't get your surface wet. In this case, we've got a pad under the patient. That's one of the other reasons we take that pad out because it's probably going to get wet as we clean. And lotion does not play a part in this. So basins or no soap zones, use paper towel to turn the water on, use warm water only, ask the patient to check it, change it if it gets cold or soapy, and we're going to use the leaves method for this. So in this situation, we're going to actually use 5 leaves. Remember I passed out the washcloths last class and we learned how to use that leaves method? We have a washcloth that is folded. So this is just a plain square washcloth, folded in half and in half again. So I've got this diamond shape washcloth that I put in my hand. Tuck in the 2 side corners, and now I have a surface to work with. For Peri Care, I'm going to use this surface to wipe. I'm going to fold it over, use this one to wipe a different area, fold it over, use this one to wipe a different area, fold that over, use this one to wipe a different area, fold that over, and I'm even going to use the back side. Now, some of you are going, I didn't know I had that many areas. So let's see where we need to wash. Yeah, we already know all this. Okay. All right. Let me go. Where is it? So when we're cleaning, we're going to wring those washcloths out thoroughly. No drippy, wet washcloths. And then we're going to apply the soap directly to the washcloth, not the patient. Do not spray a patient with soap. That's just not cool. And then we're going to use our washcloth in that same leaves method. And we're going to start at the top of the peri area and go down. It's always away from the urethra. But in order to get the center, I actually need to pull her open a little bit. Just open that labia up just a little bit so that I can get this washcloth on the inside down the center. We never go back up. It is down, away, fold. The next stroke will go on the outside of the labia. Down, top to bottom, move away, fold that over. The third washcloth goes on the other side of the labia, top to bottom, fold it over. The fourth stroke is going to go in that crease between the leg and the groin. That crease is going to hold urine. So we're going to clean the crease, top to bottom, fold that over, and clean this crease, top to bottom. Whatever we wash, we rinse. Same way. Never move back up. That's what they're looking at here. That's what they're testing. And that's because when you move back up, you are bringing bacteria from the rectal area right up to that urethra. And if you remember me saying, your urethra is only about that long. So bacteria, if they get into the urethra, very common, by the way, for bacteria to get into the urethra, but if they do, come back here. If they do get into that urethra, we have a couple of white blood cells that are hanging out there, kind of like bouncers, that say, hey, you don't belong, get out. And as long as the bacteria just come in one or two at a time, our white blood cells can handle it. But when we bring an entire busload of bacteria to the urethra, those few bouncers we have just can't capture all of them. Now, the problem is that that bladder is the ideal breeding environment. It is warm, it is dark, it is moist, and it has enzymes that help with procreation and amino acids that are kind of like an all-you-can-eat buffet for bacteria. So if we allow bacteria into the bladder, it's very easy for it to multiply. Good? Make sense? So all of our cleaning strokes are going to go top to bottom and then move away. So whatever we wash, we rinse. Whatever we rinse, we dry. Again, top to bottom. Now, after you do that, you'll cover the patient up with a privacy blanket because we have to go take care of all of our dirty things. We need gloves on to take care of all of our dirty things. We can't take that blanket off yet with gloves on. So we're going to take care of all of our dirty things, clean our basin, put it away with a paper towel, and then we can remove our gloves and remove that privacy blanket. Oh, I'm sorry. I forgot a step. We have to clean the backside too because they're laying on that pad. That backside is full of urine up against the skin. So we're going to scoot the patient toward us, roll them on their side, and we're going to wash the backside. Using that leaves method, I'm going to start at the anal opening and go up the center crease. I'll fold that over. We're going to clean one cheek. I'll fold that over. We're going to clean the other cheek. I'll fold that over, and once more up the center crease. That center crease is going to act like a riverbed. The urine's going to go right up that crease. So we get it twice. Whatever we wash, we rinse, same way. Whatever we rinse, we dry the same way. And then we're going to change that pad out again. Remember, a clean butt needs a clean pad. So we change the pad, we clean the front, we turn the patient over, we clean the back, we change the pad again. If you remember all of those principles we've learned along the way, this skill becomes super easy. Just make sure you're cleaning the right direction. Yeah, so we're going to change the pad first before we wash them because it's wet, uncomfortable. But we got a dirty butt on a clean pad. So we clean them up, front, and back, and then we change that pad again. So we've got a clean butt on a clean pad. Okay. Dispose of all your soiled stuff. Put your basin away. Remove your gloves, and then take that privacy blanket away. Complete your closing. This is not a hard skill. It's really not. It's hard on you emotionally because of where you're washing. You're not comfortable with this. But this is like every other skill that we do, guys. If your patient can do this for themselves, they will do this for themselves. We are not doing Peri Care on people that can do it on themselves. Just like we're not brushing somebody's teeth if they can do it themselves. We're not feeding them if they can do it themselves. We're only helping those that can't. Well, if somebody can't do this, we really need to make sure we're doing a good job. Any questions on this?
When you flip them over to their back or to their
Side?
do they still have to be covered?
You want to cover them as much as you can, but you're going to have to leave the butt uncovered so you can clean it. Now, there's something I want to talk to you about with that, though, because this is a mannequin, and the mannequins don't stay on their sides. So when you turn that mannequin onto their side, the evaluator is just going to reach over and hold that mannequin. They know the mannequins can't stay on their sides. You won't have to ask them to do that. They'll just reach over and hold the mannequin. In a real life setting with a real person, you put them on their side, they can usually stay there. But if they can't, if somebody keeps coming backwards, just get somebody to help you. I need someone to hold the patient. Good? Questions?
What about when it's depending on who's the skill you're doing, like for a man or woman?
So that's a very good question. So in most settings, female Peri Care will be done by female caregivers in most settings. But that doesn't mean you don't have to know how to do it. Because let's say that today everybody called in and you're the only one here. We can't neglect the patients just because we have a staffing issue. So I hate to say this because it sounds horrible, but you guys actually have a higher than average chance of getting this skill because they assume you're uncomfortable with it and you don't practice it. So you guys actually have a higher than average chance of getting Peri Care or catheter care because of that. Now, in a clinical setting, whenever possible, we're going to have a female perform female Peri Care, and males perform male Peri Care. But a lot of times we work in pairs. So let's say that you two are working on the same hallway. She's going to do all of your female Peri Care for you, but you're going to do all of her lifting for her. We play to our strengths. Make sense? So team nursing used to be a thing. And I love team nursing because it really gave the best quality of care to the patient. We all work as a team. We all have strengths. We all have weaknesses. And when you work as a team, that was great. The problem is that there's always people on the team that don't pull their own weight. And when you have somebody that's just not doing the work because they know everybody else will pick up the slack, that's not fair to everybody else. So team nursing is not as much of a thing anymore as it used to be. But if you get into a good facility with a good group, you can actually develop a cohesive working strategy.
I thought with stuff like Peri Care, there had to be two.
No. Depends on your facility, but no. Mm-mm. No. This is routine care. It's got to be done every 2 hours around the clock. And we just simply don't have the staff. Any other questions? All right, let me show you the video for this. Oh, it's the cord, yeah. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Peri Care. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back.
Oh.
Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies.
Okay,
So I'll place the barrier on the overbed table. And now I'll start
yeah, they
gathering
can,
my supplies.
they said they can hear it.
I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves.
Give me just a second. I'm going to fix this because I don't know if the people online can hear it.
They can.
They
I'm gonna
can?
fix this
Okay.
because the evaluator's just going to reach over and hold that mannequin.
Okay.
Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm. Not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth, we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soap 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed. And unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink. Rinse the basin.
Remember, no dirty washcloths went back in that basin. So it's just water.
Pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Miss Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done.
All right. Any questions on that one? They give you 17 minutes to do that. It did not take 17 minutes. This is one that you're going to be uncomfortable with until you've done it a few times. I mean, there's just no way around it. The problem is it's not really one that you can practice real well. We will have a mannequin in here next week. I do have the mannequin that you see. I will bring her in. I'm just not real sure where I'm going to store her in between classes. But I will bring the mannequin in. So next week you will have a chance to practice this on a mannequin with the supplies. The real problem here is your own emotional reaction. But I want to talk about that just really quickly. This is not the first time your patient has had Peri Care done. Remember that CNAs do normal, routine tasks on stable patients according to the care plan. If the patient was suddenly, newly incontinent, that's not normal for the patient. So who would be doing that Peri Care? The nurse. So this is not the first time that this patient has had Peri Care done. It might be the first time for you, but it's not for them. So when you understand that, it becomes a little less intimidating. Does that make sense? Okay. The best way to practice this, guys, is on like a stuffed animal at home. You can do this skill on a stuffed animal. Top to bottom. 5 leaves. Good. I know, it's a little weird, right? All right. So you have 2 chapters of homework tonight. You have 8 and 9. 8 is on nutrition. It is needlessly complex, but you do need to know the diets. So we are what we eat. I mean, in a very, very real sense. So you need to know the difference between a low sodium diet and a no added salt diet. So the book is going to go over different diets. Chapter 9 is on rehabilitation. So it's kind of an interesting chapter. It's going to talk to you about different things that we can use to accommodate the patients to help increase independence. So it's kind of an interesting chapter. And then after that, you only have 1 chapter left. So you're on the downhill slide now. There's only 4 skills to learn on Wednesday or on Monday. We're going to learn catheter care, which is just like Peri Care with an extra step. We're going to learn bedpan. That's a pretty easy skill to do. We're going to learn how to empty a urinary drainage bag. And you guys all have a drainage bag in your kits. And we're going to learn our last range of motion, which is the one we should have done during week 2, but didn't get to. Okay, good. But that takes like 3 minutes to teach you because you already know everything you need to know about range of motion. So I gave you your review sheets. Does anybody have any final questions for me today? Any final questions?
This skill is a very long one as well.
It is 17, they give you 17 minutes to do. So if you get this skill, you're going to get 2 short skills. In fact, if you go to page 24,
Do you see the one in the middle of the very middle of the page? It's got 34 in the little clock thing. That is the care plan set that has Peri Care on it. So you would have to do pulse and range of motion of the shoulder, which is what we're going to learn next week.
So is this exactly how it would be?
That is
If you got
exact.
that, you would have exactly those. two
Those
other two.
are the care plans from the state exam, the actual care plan sets. And you have these in your kit. You have these. This is what's on this page. So these are the actual care plan sets. So if you get Peri Care, you're going to get range of motion, shoulder, and pulse to go with it. Any other questions? Questions? All right. The rest of the class is practice. So again, I can't keep you here, but I will ask Jake to move the bed up here so that you will be able to practice transferring out of bed and into a wheelchair or any of the skills that we've learned up to this point. And I'm here to help you. You also have your practice kits. So if you're not practicing here, make sure you're practicing somewhere. You don't want the first time you do a skill to be for the test. That's not a good strategy. So if you're not practicing here, make sure you're practicing somewhere. And then 4 more skills on Monday, and Wednesday we graduate. Good job.
How do you practice the wheelchair one at home if you don't have a wheelchair?
You can use a regular chair and just practice the transfer part. But I would practice at least using the wheelchair while you're here, getting familiar with how to do the brakes and how to adjust the leg rests and the foot pedals and that kind of thing. Yeah. Most people don't have a wheelchair at home, so.
Oh, wait, my grandpa.
Oh, there you go. Hey, good job. Okay. So where do I find my Prometric ID? Oh, that's a good question, Marcia. So you're only going to have a Prometric ID after you register for the test. So initially, when you first register, there's going to be a spot for a Prometric ID. Skip it. You don't have one yet. But once you register for the test, if for some reason you have to contact them because you don't have your test date yet, and it's been, more than 2 weeks, you need your Prometric ID. They're going to send it to you in an email. Do you remember do you remember this? Do you guys remember this? When you register for the test, you're going to get this and it's going to say, here it's going to say complete, right? When they have everything, your background check and your payment and everything. Up at the top, way up here is your Prometric ID. So you get it in your email. You're going to need this if you have to contact Prometric. This is important. You're also going to need it if you have to register to retest. So if you fail a portion, if you fail the written or fail the skills and you have to retest, you'll need your Prometric ID for that as well. I hope that helps, Marcia.
There's one more.
Okay. I have some difficulty with getting registered. Marcia, if you go to flcnatraining.com. So we just put it in the chat, flcnatraining.com. Scroll down the page until you see class 4. Off to the side, so you'll see a thumbnail that's a replay of class 4 from in here. Then there's the review sheet, which I just passed out. And then next to that is test registration instructions, a video. Click on that and watch it. It goes through step by step how to register. Everything is covered in that video. That should help you. Okay. All right. Any other questions? I'm losing my voice, guys. Any other questions? All right. The rest of the class is practice. Take a break. Do whatever you'd like to do. Those of you who are joining us live, thank you so much for joining. We'll be back on Monday. If you did not get a chance to join us for the game show, go back and watch that because those questions are going to be super important on the state exam. Till next time, happy caregiving. Bye.